I'm Jenny. I'm one of the PGY5. This is my senior lecture on hypertension management in the emergency department. So kind of my first question is, should we be treating asymptomatic hypertension in the emergency department? So everyone kind of has their own approach on when to treat this. There's a lot of reasons not to. In the outpatient world, we don't treat hypertension based on one visit's blood pressure, right? There's kind of the well-documented white coat hypertension where you have kind of that stress from being in a healthcare setting and a patient's blood pressure gets elevated. Obviously, patients who come into the emergency department for a specific reason, whether they're in pain, anxious about something affecting their health, can all contribute to elevated blood pressure. So I'm typically inclined to leave these pressures alone, make sure the patient has good access to a primary care doctor, and I'll usually advise the patient to get a home blood pressure cuff, measure their blood pressure at home, and keep a log to take to their next PCP appointment, which for some of our patients, who consistently lack access to care or have difficulty navigating the healthcare system can be almost like a pipe dream. And so we know there's risks to very high blood pressure in the short term, like development of acute pulmonary edema, hemorrhagic stroke, but in general, good blood pressure control over a long period of time is what offers the cardiovascular protection that we're looking for, which starts with good connection to primary care. But there are some cases that will lean towards treating. So for example, patients who have very high blood pressures consistently. And those patients who keep getting sent over from clinic after we've referred them to clinic because by the time before they even see a doctor, they get triaged and their blood pressure is 250 over something and they get sent to the ER, kind of repeating that cycle, which is frustrating for the patient, frustrating for us. And then, there's also, patients in the observation unit sometimes when we're kind of hanging on to for a couple of days, and get called about high blood pressures, systolic of overnight in the 170s. I guess my question to you guys is, if you get called for a blood pressure in the observation unit overnight, it's systolic is in the 170s. Do you decide to treat it? Any opinions on that? Sure, great question, right? So are they having symptoms? What's a lot of times we have patients who are waiting for placement, right? And so if the patient's there because they have dementia and they're waiting for and they're getting agitated at night at home and that's why they're there, then your answer would probably be stopping their blood pressure at night, let them sleep, maybe their blood pressure won't be elevated. So there have been a lot of, or not a lot, a couple of observational studies over the last couple of years that have looked at controlling blood pressure in the acute setting, meaning typically in the emergency department as well as the inpatient setting. So kind of in contrast to the outpatient setting where we typically will titrate blood pressure medications. And so these are two of the main ones that I've seen referenced. So the first study looked at patients hospitalized for non-cardiac diagnoses, which is an important point, at 10 hospitals in the Cleveland Clinic Health System. And they found that 78% of patients had at least one elevated blood pressure reading prior to discharge, but about 1 in 3 of these patients either received an acute hypertensive treatment, which was defined as either an IV push medication, like hydralazine, labetalol, that we typically use, or the addition of a new oral agent. And they kind of looked at, after kind of controlling for confounders, which were pretty prevalent in the study, kind of being an observational study, they found that patients received this treatment had higher rates of AKI and myocardial injury than untreated patients. In the second study, they were looking at, it was at a VA hospital, it was a little bit larger, where they created this composite measure looking at inpatient mortality, intensive care unit transfer, stroke, acute kidney injury, some cardiac markers, and found that patients who received kind of the same definition of acute hypertensive treatment were more likely to experience this adverse composite outcome. Now, with the second study, I am a little more inclined to think that it kind of suffers from the bias that sick people are more sick and people who they felt the need to treat with more antihypertensives were already kind of on the path to maybe needing a little bit more in the hospital. But I think the one compelling thing that I've kind of seen, not in any that I haven't seen any RCTs on this topic to my knowledge, but a lot of these kind of observational studies have kind of suggested that aggressively treating blood pressure in the acute care setting causes more harm than good, which leads to can lead to more episodes of hypotension, not adherence to complicated regimens once a patient's discharged, because, they may not have, kind of that appropriate connection to care, which is really what's going to determine, if the patient's successful in controlling their blood pressure. But that brings me to my next question. If we agree that most of the time we decide not to touch these pressures in the acute care setting and make sure we connect our patients with that ambulatory referral to med primary care, are there instances where we do want to treat these patients? And my answer to that is absolutely. So I think everyone has their own threshold and rules around this. So I want to kind of offer mine and also what I found in the literature. I think ASAP put a statement out that in general, we don't want to be treating asymptomatic hypertension in the emergency department. I think we would all agree with that. But for patients who, especially in our community, who have kind of this markedly elevated blood pressure, kind of defined as a systolic consistently over 160, personally, if I see that plus LVH on their EKG, if I can see that they've had, several visits in the past where they've had consistently elevated blood pressures when they went to, the dental clinic, when they went to get their COVID vaccine, things like that, I'm a little bit more inclined to want to start something for them and then kind of connect them to care. And then regarding patients admitted or on the observation unit, we are definitely managing our CHF patients' blood pressures, whether they're kind of a new CHF or someone who came in very hypertensive and maybe, experienced some fluid overload in that situation. But there's also some other situations where we might choose to intervene. So for example, a patient on the hyperglycemia pathway that just connected back to care is severely hypertensive during the 24 to 40 hours that we're observing them. That's a patient that might benefit from a little bit of intervention as we connect them to care. But when we do make the decision to start treating a patient, it's important to be thoughtful about the choice that we make as much as we can. It's a little bit, it's in our scope as emergency physicians, but it's also sometimes something that we don't feel that comfortable with because it feels very much like kind of an outpatient, problem, and sometimes it is, but it is something really helpful that we can do for our patients by making sort of an informed choice about the blood pressure medications that we start, because people are much more likely to, when they're coming into the hospital saying, I have this problem, very concerned, proper education in that setting and starting them on a medication can potentially, increase their adherence to medication and kind of help them understand the importance when they're in that kind of mindset of I've come to you and I need help. So so kind of that kind of brings us to the question, what medications can we use? So we learned about all of these different classes of medications in medical school, and I will say for me, a lot of them just didn't stick until I I took step one, then kind of went out of my mind, took step two, and then kind of went out of my mind. But they really sort of started to make more sense to me as I started treating more patients with these medications, seeing the side effects, and then kind of titrating them myself. And so I mainly want to focus on ACE inhibitors, angiotensin receptor blockers, thiazide diuretics, and calcium channel blockers, because these are all acceptable first-line agents for blood pressure control. There are obviously other agents that find their way into blood pressure control regimens, like beta blockers for certain types of patients, like those with heart failure. They're not great blood pressure medications, but and we also, in pregnancy, we often use labetalol. And there's also nitrates, direct vasodilators like minoxidil, hydralazine. I won't even touch on clonidine because that's when we're getting really desperate for blood pressure control. And that's not really kind of the medications that we're going to be titrating in the emergency department. So just to touch briefly on some of the mechanisms of these medications. So does everyone remember how do I know it's kind of almost painful to look at, but how do thiazide diuretics work? I put it up there, so yeah. So we're blocking a sodium chloride transporter in the kidney's distal convoluted tubule. So less sodium chloride are reabsorbed. Water follows. This leads to a reduction in blood volume, which leads to a reduction in blood pressure. So downsides of thiazide. So we see a lot of our patients on hydrochlorothiazide and chlorthalidone, which are the kind of our two main thiazides. But this can lead to hypokalemia and hyponatremia. The hyponatremia is a direct effect, right? And then the hypokalemia is indirect, right? Because the higher delivery of sodium to the distal tubule results in more potassium excretion. We see this particularly with chlorthalidone. There are some patients that PCPs will put on chronic potassium supplementation because the effects are so strong. And so during residency, they've actually taken a lot of older patients off hydrochlorothiazide and chlorthalidone because they get admitted all the time for electrolyte abnormalities, orthostatic hypotension. It's considered still first-line treatment for hypertension for African-American patients, based on a study that I'll talk about in a little bit here. And they're considered very good medications based on the studies that have been done on hypertensive control and kind of downstream cardiovascular events. But I think it's important for us to be aware of the side effects that exist and kind of decide amongst ourselves if these are the best choices for our patients in the moment. Next, so how do calcium channel blockers work?
Calcium channel.
Exactly. So yeah, they prevent calcium from entering the heart and blood vessels. So this relaxes the vessels, slows the heart rate, which also lowers blood pressure. So they block specific L-type calcium channels in these tissues. So this is kind of there are the two different types, which are actually pretty relevant to our practice in the emergency department. So we have the non-dihydropyridines, which are verapamil and diltiazem, and then the dihydropyridines, which are amlodipine, nifedipine. And so amlodipine and nifedipine are great for choice for the vast majority of patients who are African-American, Afro-Caribbean. And a commonly described side effect of calcium channel blockers is lower extremity edema, which can resolve on discontinuation of the medication. But I mean, we talk a lot about amlodipine is often a first choice for some of our patients, which is for the most part a pretty good choice. But we'll talk about that a little bit. We also kind of want to use caution with patients who have any evidence of heart failure. Does anyone know why? Yeah, exactly. So so basically, if we have a new patient that comes in, if they're coming on to observation, if they're coming, or if we're kind of concerned at all about a new diagnosis of heart failure, or they have a known diagnosis of heart failure, and we want to start them on something for hypertension, calcium channel blockers are well documented to have negative inotropic effects, which can be very detrimental for patients in heart failure. This is a little bit less true of the dihydropyridines because they affect more the smooth muscle and the vasculature versus the heart, but they're still in effect. And so there are better choices for patients who have heart failure. And to kind of deviate from hypertension briefly, one point very relevant to our practice in the ED is whether it's appropriate to use diltiazem for AFib with RVR for patients with heart failure with reduced ejection fraction, given the negative inotropy. So the recommendation for ongoing rate control, kind of their home medications, is oral metoprolol in these patients, which makes a lot of sense because it's part of our GDMT for heart failure with reduced ejection fraction. But regarding this kind of acute setting, I wasn't only able to find like 3 small observational studies that explored whether it was appropriate to use diltiazem IV to control AFib with RVR in these patients with reduced ejection fraction, and they all had wildly different conclusions. And so I think it's biologically plausible that it could be harmful to these patients to use diltiazem in this acute setting, particularly if they have a very low EF. I don't know if it's enough to kind of change my own practice in that. I do, anecdotally have a little more success with diltiazem in getting rate control in AFib with RVR, but it's something to at least think about, especially if you think your patient also is, having a heart failure exacerbation and they're in AFib with RVR, maybe thinking about using metoprolol as your first line agent could be part of your thought process. But the evidence is really not quite there yet. But so lastly, to kind of quickly review, does anyone remember how ACE inhibitors and ARBs work? This is the last one, I promise. So they have two ways of inhibiting the effects of the renin-angiotensin-aldosterone system. So ACE inhibitors inhibit ACE, which prevents the conversion of angiotensin 1 to 2, which leads to the vasodilation and reduces blood pressure. They also prevent the breakdown of bradykinin, which is also a vasodilator. So they have that extra effect of reducing blood pressure. But bradykinin, if you guys remember, is also what mediates a lot of the side effects of ACE inhibitors like cough and angioedema, which is actually of note in our African-American patients. They're more likely to experience angioedema from an ACE inhibitor than non-Black patients, kind of well documented in the literature. And angiotensin receptor blockers work a little bit differently. They block the angiotensin receptor, so they prevent the downstream vasoconstricting effects and then cause vasodilation. They're both renoprotective, which is an important point because through inhibiting the effects of angiotensin 2, they reduce can't say this word ever, glomerular pressure, which helps directly decrease damage to them, reduces proteinuria. So in a patient with hypertension and diabetes, both of which damage the kidneys, this class of medications is especially good at preventing CKD and the progression of CKD. It's a common misconception that you can't start a patient on an ACE inhibitor or an ARB if they have any evidence of kidney disease, but they actually continue to be protective in mild to moderate CKD. So unless your patient is demonstrating acute electrolyte abnormalities from advanced CKD or has an AKI, it's typically safe to initiate an ACE or an ARB, and it'll probably be beneficial for this patient in the long term. So there's a major trial that forms the basis for how we typically approach first-line antihypertensive choices. So the ALLHAT trial began in 1994. Mean follow-up time was 4.9 years. It was published in 2002. It was a large, well-powered RCT. Results from the study formed the basis for the JNC8 guidelines that came out in 2013 and the 2017 hypertension clinical guidelines from the American Heart Association. The important point from this is they looked at monotherapy. So they looked at 3 first-line antihypertensive medications. So they looked at lisinopril, which is an ACE inhibitor, amlodipine, a calcium channel blocker, and chlorthalidone, which is a thiazide diuretic. And in terms of their primary outcome, they didn't find any significant difference in the incidence of combined fatal coronary heart disease or non-fatal MI. But their subgroup analyses is actually where we got a lot of our recommendations. And so just kind of relevant to our populations, how we approach this on RER. Their racial subgroup analysis had significant effects on how we approach this. They found this study, in this study, that Black patients benefited more from thiazide diuretics and calcium channel blockers, and that they were more effective than ACE inhibitors in lowering blood pressure and preventing cardiovascular events. But an important thing to remember is that they studied monotherapy in this trial. And since then, there have been some smaller trials that kind of looked at different combination therapies in different populations, but nothing that kind of came to mind that's nothing that I found that has really had a significant influence on guidelines. So this kind of brings us to the question, okay, so say we've decided to treat our patient's blood pressure and you want to give them something that's appropriate until they see their primary care doctor. So I guess kind of what would say we have a patient that has a high blood pressure in the ED, a couple of readings, we got some labs on them, they're normal. What would you want to start before they see their PCP? I was like, what's our favorite one to send people home on? Amlodipine, right? And it's a good blood pressure medication, right? You can start it without looking at someone's labs. It doesn't affect electrolytes directly. It's generally well tolerated. It's cheap. It's cheap even without insurance. And there are a lot of patients for which this is an entirely appropriate choice, right? And so I agree that amlodipine is a good choice for a lot of patients, but in our population that are primarily Afro-Caribbean, there are thiazides are actually kind of recommended as a more appropriate choice. But I was like, I have seen a lot of patients who are older come back kind of with those electrolyte abnormalities, but starting it when they're younger and giving them that chance to see if it's helpful makes a lot of sense, and the evidence supports it. So so this graphic kind of breaks down how we approach it's kind of from the from the JNC8 guidelines. It first stratifies by whether the patient has diabetes or CKD. And if they don't have these things, or if they don't have these things. And so if you have diabetes or CKD, your first line treatment is actually still recommended to be an ACE inhibitor or an ARB, regardless of race, because of the nephroprotective effects. But and kind of an important point here is when we have patients with severe hypertension, we don't have to start just one agent at the same time or initially. We can give them kind of those protective effects of the ACEs and ARBs, along with giving them a thiazide, which is proven to be a better blood pressure control medication for a lot of these patients that we see. And then, so non-Black patients are actually recommended to start any of our 3 medication classes as a first-line agent if they don't have CKD or diabetes. And so, and then I kind of like this graphic because I like the little gray box where we talk about lifestyle changes. Again, we obviously are not primary care doctors in the emergency department, but we always have an opportunity for education for our patients. There have been some studies that have shown that because of kind of that salt wasting component for African American patients, that basically the thing that makes them respond more to thiazide diuretics also makes it so that patients who make lifestyle changes, such as kind of adopting a DASH diet, low salt diet, they can actually see pretty significant effects where other populations may not. And so taking that time to kind of counsel your patient on lifestyle modifications can be very, very helpful. And so just a few takeaways. I think in OBS and on the medicine floors, we often get some pressure to treat hypertension very aggressively. And it's important to remember the reason we're checking vitals so often is not to titrate someone's outpatient hypertension regimen. In most cases, we're really looking for severe hypertension and hypotension. So we want to address any underlying causes like pain, agitation. I think we do a good job of making referrals for outpatient care. But as I've mentioned, I think it does a lot of value to have a conversation about the danger of hypertension, effects on the heart and brain and kidneys. People listen more when something acute is happening, more than they might listen to their primary care doctor. And like we talked about, amlodipine is a great choice for a lot of our patients, but the patient has any evidence of heart failure, it's not good for them. And in our Afro-Caribbean and Black patients, it may be helpful if you're comfortable starting a thiazide diuretic. And then next, if you're in a position where you're starting or modifying therapy, don't be afraid to explore starting an ACE or an ARB or combination therapy, especially if you have baseline labs in the patient. If you know they don't have an AKI or hyperkalemia, like I mentioned, they're not ideal monotherapy, but for our patients with diabetes as well as hypertension, they absolutely should be on an ACE or an ARB, particularly if they're starting to show any evidence of albumin in the urine, which we may or may not check. And then lastly, don't hesitate to discontinue medications that have demonstrated an adverse effect in a patient. A lot of our patients are appropriately started on thiazides, but if they're elderly, experiencing orthostatic hypotension from overdiuresis, hyponatremia, hypokalemia, it's a good idea to kind of reassess if there's a better agent available for them. And so that's all I have. Just kind of a quick thank you to this wonderful program. I came to this program 9 months pregnant, and it has been kind of through the support, of people in my class, and then Dr. Gennaro, Dr. Willis, Dr. Schechter, who offered me a lot of support to have 2 kids in this residency. I definitely would not have been able to do it without being able to reach out to them and have them rearrange my schedule to make make everything work and still complete my training. And then a very, very big thank you to my very best friend, my husband, who's been with me through a lot of different phases of life, encouraged me to go to medical school, didn't freak out when I wanted to do a 5-year residency, and said definitely not when I mentioned fellowship. So he did a really wonderful job of being the primary parent to our 2 kids when I had very busy months in residency, while working sometimes 2 jobs and kind of chasing his own dream job, and allowing me to do the same. So very grateful for that. Grateful to all of you.